Good evening, ladies and gentlemen. I'm Dr. Niroshan Lakunarangode. On behalf of Ceylon College of Physicians, I warmly welcome you to the cutting-edge lecture series with international faculty. May I invite the President of Ceylon College of Physicians, Dr. Anusha Nayak, to speak a few words. Over to you, sir.
A warm welcome to all of you in today's online audience. A good evening to all of you. This is part of our cutting edge series of lectures. Now, when we set out the CCP in 2022, the objective was to learn from all sources that we have access to. So as part of the peer learning program, we have three facets. One is, of course, we learn from our colleagues in smaller hospitals in the peripheries of Sri Lanka. We learn from them about how they manage with limited resources, complex problems, and that program has been very useful and fruitful. Then, of course, we have our very senior colleagues, very often past presidents of the Ceylon College of Physicians, who speak to us about the wealth of experience that they have accumulated over the years, so that all of us can learn from their experiences and then become better ourselves. This is the third series. Here we get a clinician of international repute to speak to the members of the Ceylon College of Physicians on the newer developments and the newer perspectives of some clinical phenomenon. This being the month of respiratory medicine, we have today Dr. Thomas Brown, who will speak to us on recent advances in asthma. So the idea is that we will have this lecture as well as a Q&A session, and then we'll all become better in our clinical delivery of this new knowledge, transforming knowledge into clinical practice. So I invite the members in the audience to continue to engage with the CCP in time to come in all of these programs, and then be that much better in caring for our patients that we will see in our clinics and our wards. Right, thank you very much. So that's a brief introduction of this program. And I'm, again, as president, I'm very grateful to a couple of people, Dr. Brown for consenting to speak today, as well as Dr. Riaz and Dr. Chandimani, who are coordinating this program on behalf of the respiratory team, and of course, Dr. Niroshan Lakunarangode, who is our lead for the cutting edge series. So I will hand it over to Dr. Niroshan Lakunarangode to formally introduce our guest speaker of international repute, who is going to speak to us today. Over to you, Niroshan. Thank you very much.
Thank you, sir. As mentioned, for today's lecture is on advances in asthma care by consultant respiratory physician at Portsmouth Hospital University. After the lecture, there will be a short Q&A session. This will be moderated by Dr. Riaz Mawjood, consultant respiratory physician. I invite all of you to take part by sending your questions to the chat box during the lecture. So it's my great pleasure to introduce our distinguished speaker, Dr. Thomas Brown, for today's lecture. He is a consultant respiratory physician at Portsmouth Hospital's University NHS Trust, where he leads the Portsmouth Severe Asthma Center. He is also the Deputy Director of Research with a specific interest in novel diagnostics and phenotyping in asthma. His PhD in asthma described the Wessex severe asthma cohort, and he is the joint clinical champion for NHS England Accelerated Access Collaborative for Fractional Exhaled Nitric Oxide. Dr. Brown leads the CRN Wessex Research Fellow Program and is Joint Deputy Training Program Director for Respiratory Medicine in Wessex. He has been involved in award-winning innovative research projects such as Mission Asthma, Mission ABC, providing novel vertically integrated clinics in the community revealing patients with asthma, COPD, and breathlessness. Today's topic is advances in asthma care. I am sure that this lecture would encompass changes in treatment strategies across the asthma severity spectrum. This will be really useful for most of us practicing clinicians. I hope this will touch some novel area like carbon-friendly prescribing. On behalf of Ceylon College of Physicians, again, I would like to thank you, sir, for accepting our invitation in the middle of your busy schedule. Over to you, sir, for your lecture. Thank you.
Thank you very much. Well, thank you very much for that very kind introduction. My name's Tom Brown. I'm a chest physician in Portsmouth in the UK, and it's a really great pleasure to be able to speak to you today about advances in asthma care. So these are my disclosures just to share with you. And as I've said, I work in Portsmouth, which is on the south coast of England, and we're incredibly proud in Portsmouth of our strong links with Sri Lanka. We've been lucky enough to have trainees come over to us from Sri Lanka, and it's really fantastic now to see how they're thriving and contributing to the healthcare system in Sri Lanka, which is really wonderful. So for those who haven't been to Portsmouth, it's on the south coast of the UK, and we're very proud of our shipping in Portsmouth and also of the Spinnaker Tower, which sits down on the south coast. And looks out towards the Isle of Wight. And in Portsmouth, I lead the severe asthma service. And asthma is a real problem across the world, and we still know that asthma contributes to a huge number of deaths. There's over 300 million people with asthma, and it's causing over 460,000 deaths a year. And in the UK, similar to Sri Lanka, actually, it's a growing problem. We've got over 5 million people with asthma, and we know that a large number of those patients don't have well-controlled asthma. They still suffer symptoms and attacks. We still see a significant number of deaths, and it's incredibly expensive to manage. It costs our healthcare system in the UK about £1 billion a year to manage, but the wider costs are huge to the economy, equating to nearly £6 billion a year. There are a large number of hospital admissions for asthma, so over 75,000 admissions a year for asthma. And I can see from the statistics in Sri Lanka, that's also a big problem for Sri Lanka. But what's important as well is we know there's a lot of patients who are taking lots of oral corticosteroids to try and manage their asthma. And actually what we're seeing is those figures aren't really improving. And what we've seen over the last decade, despite great strides to try and improve asthma care, actually we've seen an increase in the number of asthma attacks people are suffering, and actually an increase in asthma deaths over that period as well, which is certainly worrying. So I want to talk about a few aspects of advances in asthma care, focusing on some new drugs, but also the new evidence around some of the drugs we already have available. And I want to start by talking about inhaled corticosteroids. These have been around for a long time, and I think everyone's familiar with their use. But how we use them and where we implement them in our treatment pathways is incredibly important. So I'm sure many of you will be familiar, and this is across GINA guidelines or BTS guidelines, or whichever guidelines that people are following. Inhaled corticosteroids have become the standard therapy for people where we're convinced they have asthma. This is the treatment they should be started on. There are a few exceptions to that, but essentially anyone who's having asthma attacks, if they've had an asthma attack in the last few years, anybody who is requiring anything more than a small amount of their short-acting bronchodilator, so having more than 3 puffs a week of their Ventolin or salbutamol inhaler, or suffering symptoms or waking at night, these patients should all be on an inhaled corticosteroid. That's quite a big change because historically we've recommended these patients should be on a short-acting bronchodilator. So why? Well, this kind of graph really indicates exactly what's happened. So many of you are familiar with this. So since 1960, we've had novel treatments for asthma. And first there was the Bronchodilator era. So this is where we gave everybody long-acting bronchodilators or short-acting bronchodilators. And what we saw was an improvement in symptoms, but very little change in mortality. And the reason for that was we could mask the symptoms of asthma, but we weren't treating the underlying problem of inflammation. And it's only when we've started to focus on treating inflammation that underpins asthma and causes exacerbations and some of the severe problems and side effects we see that we've really seen some traction. But even then, we still haven't seen a significant reduction down where we would like asthma mortality to become a thing of the past. So why might this be the case? So I just want to share with you a case presentation of somebody I've seen in clinic not that long ago. So this was a patient who came to see us. He was a 17-year-old student studying for his A-levels in the UK, and he was hoping to study law at the university following a long family tradition. So I was very fortunate in the clinic to see him alongside a whole group of family lawyers who were all making lots of notes as we discussed his case. And essentially, he told me he'd suffered asthma in early childhood, but he'd been really well after that for many years, although he did have hay fever. He had a blue inhaler, his salbutamol inhaler, but he rarely used it, and he denied having any asthma symptoms. He'd suffered with whooping cough as a child and was allergic to penicillin. Told me he was allergic to penicillin and had an anaphylactic reaction to that in the past. No other significant past medical history, though. Lived with his parents, his younger siblings, and their 2 dogs at home. And his mother and maternal aunt both had asthma. And his grandfather had this unusual history of COPD, but he'd never smoked and he had no history of industrial exposures or any real reason to explain that. And he came to see me because he'd suffered a chest wall injury playing football with a friend, and he'd been seen in the emergency department, and a chest x-ray had been done to look for a pneumothorax. That hadn't shown a pneumothorax, but it had shown bronchial wall thickening and slightly hyperexpanded lung fields, which we were struggling to explain. He came to see us in clinic and underwent the sort of normal testing that you might undertake. So he underwent lung function testing with spirometry. And interestingly, that didn't show an obstructive forced expiratory ratio, but it did show a reduced FEV1. So the amount that he could blow out on a forced breath in the 1 second was reduced really from what it should have been at about 75% predicted. And so we went on to do some further tests, because looking at his flow volume loop, which you can see here on the right, you can probably see there's some scalloping in the inspiratory limb there, and sorry, in the expiratory limb. And so we were concerned that actually he did have underlying airflow obstruction. So he went on to have plethysmography done, which is where you go in the body box. And that showed his small airway resistances were actually raised to 246% of what they should be. We did bronchodilator testing, and he did reverse, perhaps not to the 12%, but nevertheless, there was bronchodilator reversibility. And actually, his residual volume as a ratio of his total lung capacity was quite elevated at 134%, despite a normal transfer factor. So some physiological gas trapping. In the UK, we also use oscillometry now, which is you fire a sound wave down the airway, and it gives you an idea about resistance in different parts of the airway. And what you can see from that is his small airway resistances were really quite elevated. He had a pheno test performed, which is a measure of type 2 airway inflammation, which was raised. He was allergic to grass and house dust mite with an elevated total IgE. And his peripheral blood eosinophil count was raised at 0.4 with a raised eosinophilic cationic protein, suggesting an underlying type 2 phenotype. He went on to have an inspiratory an HRCT, because we couldn't really explain the features on his chest x-ray. We wanted to exclude obliterative bronchiolitis. And interestingly, he managed to breathe out during his CT. And what you can see is when he breathed out, he's got quite significant gas trapping, which backs up what we could see. So this is an ostensibly well, young patient with significant gas trapping, abnormal lung function, but who tells us he's got absolutely no symptoms. He went on to have sputum induction, which showed 8% eosinophils in his sputum. And what the problem we're identifying here is that in the vast majority of cases, despite perhaps treating their asthma with a short-acting bronchodilator, actually airway hyperresponsiveness and chronic inflammation very frequently persist, even when the symptoms are absent and lung function can even be normal. And the problem is that we have to remember asthma is an inflammatory condition. And the pictures here are really just showing you the airways in asthma. And what we have to remember are there are things in asthma that we can see and we react to. So a patient's symptoms, lung function, but there are things we don't know about and we're not looking at. And unless we proactively look for them and treat them, our patients won't get better. And these are inflammation and airway remodeling. There is a huge body of evidence, which is quite extensive and irrefutable, that tells us that inhaled corticosteroids are the right treatment for our patients with asthma. They dramatically reduce exacerbations by up to 50%. They reduce hospitalizations and they reduce asthma deaths. And they hugely improve symptoms and quality of life. Many of you will be familiar with the Sweester study, which now dates back to 2000. So we've had this evidence available for a long time, but it's been replicated across multiple other studies. So the START study here showing you a very significant prolongation to the time of a further exacerbation. And again, a very significant reduction in exacerbation frequency, but also oral corticosteroid use. We're all familiar with the very significant side effects of oral corticosteroids, trying to reduce the exposure that our patients have to those treatments because of the problems they can develop with multiple courses. And we know that with a stepwise approach, the vast majority of patients can achieve good control of their asthma. so about 75% in the GOAL study. But what about in real life when we give patients these treatments? And a huge program has been undertaken in Finland, which has really led the field in terms of implementing this since 1990. The Finnish ministry decided that they wanted to make a significant change in asthma outcomes. And so they implemented this comprehensive change in asthma management. And a very major part of that was to change the way they treated asthma. They wanted to treat with preventer medication, not reliever medication. And so in all cases, they incentivized the use of inhaled corticosteroid preventive treatment. And they saw a dramatic reduction in asthma deaths, a dramatic reduction in hospital admissions due to asthma, and really a significant impact in terms of patient benefit with a reduction in days of work lost and a reduction in the annual costs of asthma. And they continued to implement that program. And over 13 years, they saw that those improvements were maintained. And that's really revolutionized the way that they deliver healthcare, and something that across Europe we've all been trying to learn from. So what are the problems with mild asthma and short-acting bronchodilators? Well, the problem is mild asthma doesn't really mean that it's mild. People with mild asthma can come to fairly significant harm. So if you look at the data, about 30 to 50% of patients with acute asthma had symptoms less than weekly or only on exertion before that happened. And actually, in that group who had relatively infrequent symptoms, 16% of patients with near fatal asthma and 15 to 20% of adults with asthma who die actually don't have significant burden of symptoms. It's also really inconsistent for our patients. We say to them at step 1, take this inhaler, you'll feel immediately better and it's the treatment for you. But then as their asthma gets worse or their symptoms get worse, we say, no, you mustn't use these treatments. They can be bad for your asthma and we need to avoid them. And patients get very confused. They get very reliant upon their reliever medication, and they don't really understand our messaging around preventer medication unless we institute that right from the beginning. But there's also an increasing body of evidence that the use of short-acting bronchodilators can cause problems, because essentially they cause the beta receptor regulation to change. And so patients become reliant on their beta 2 agonists. And actually, when they take them, that causes reduced bronchodilation, so they don't get the same benefit. And actually, it can increase bronchial hyperresponsiveness. And there's some evidence it can also start to increase inflammation and allergic responses and potentially viral susceptibility. So we know that there are significant problems with overusing short-acting bronchodilators. And it's really important that we think about, well, what happens to patients who've got mild asthma? The graph here is showing patients at the different GINA steps. So step 5 is those patients on maintenance OCS at this stage. So those are the most severe patients. And as you might expect, those patients are at the most significant risk of harm. However, when you look at asthma deaths, the next most significant group are those at step 1. At that stage of the GINA treatment algorithm, that was just short-acting bronchodilators only. So we really do know that that group are at risk. So what's the problem? We know maintenance or inhaled corticosteroids are the right thing to do. The problem is patients simply don't take them. Adherence is around 25 to 35%. So we can prescribe them, but patients don't take them. And when patients have been asked about this, if you look at focus groups of patients, so this is the AIR study, a huge study across Europe, looking at adults and children, you can see that the vast majority of patients, nearly 2/3, are using their reliever medication, but only less than a quarter are taking regular inhaled corticosteroids. And surprisingly, this is the same in adults or children. And another big study, the INSPIRE study, which looked at nearly 3,500 patients with asthma, so a physician diagnosis of asthma, patients on regular inhaled steroids or inhaled steroid LABA combination inhalers. Actually, nearly 40% of those patients didn't feel they needed to take their preventer medication every day if they felt okay. And actually 90% of those patients just wanted immediate relief treatments. So we need to really educate our patients around what they need and why they need these treatments. But another big change is, well, why don't we think about giving these patients inhaled corticosteroid long-acting bronchodilator treatments when required right from the start? And this body of work has really been growing over the last 5 to 10 years. And this was the first study, the Sigma-1 study that was published, a big study looking at mild asthma. So this was GINA step 2 patients. And they compared the use of short-acting bronchodilators versus inhaled corticosteroid LABA when required inhalers versus using an inhaled corticosteroid as a fixed dose maintenance, perhaps what we're all most familiar with. And essentially, they looked at a group that really did fit into that unstable, but at the low dose ICS range treatment. And what they found in Sigma 1 was when you give those patients the ICS-LABA treatment, they have the same reduction in exacerbations when you give it when required versus giving a fixed dose inhaled steroid regime. But perhaps most importantly, you can use a very significantly lower dose of inhaled corticosteroid. So these are the combination inhalers. So in the UK, the very commonly used ones would be, for example, Foster or Symbicort, but these studies were all done using Symbicort. So that is budesonide and formoterol as a combination. And that's really important because you need to use formoterol because that works very quickly. So patients do get the immediate relief as they would with a short-acting bronchodilator. But importantly, in these early studies, it did appear that whilst exacerbations were still reduced, actually patients appeared to have better symptomatic control when they were using an inhaled corticosteroid fixed dose regime. And this was replicated quite rapidly in the Sigma 2 study, which was also published in 2018. And this study looked just at inhaled corticosteroid LABA when required treatment versus a maintenance inhaled corticosteroid and short-acting bronchodilator. So comparing perhaps what is our recognized standard against this new idea of ICS-LABA when required. And again, they showed no difference between the two in terms of reducing the frequency of severe exacerbations. But again, they showed a very significantly lower requirement for inhaled steroid. So those patients using the when required treatment were using, on average, 66 micrograms of ICS daily compared to just under 300 micrograms in the other group. But again, they saw a slightly less favorable response in terms of lung function, although it was well below the minimally important difference and perhaps in symptom scores, but again, below the minimally important difference. So still not quite clear whether this was going to be good for symptoms and lung function, but definitely equivalent in terms of exacerbations. But these were quite tightly controlled studies looking at quite a focused group. So more pragmatic studies have subsequently been done. And these are looking again at using the combination of an ICS-LABA when required versus an ICS fixed dose with a short-acting bronchodilator. But as I say, much more pragmatic study designs, looking at real-world populations and categorizing exacerbations as urgent medical consultations, the use of oral corticosteroids, or having to use lots of a short-acting bronchodilator. But again, a mild population. So only 50% of these patients had only used their short-acting bronchodilator 2 or less times in the week, last week of enrollment. And what they found in this study, which was a big study, so 675 patients over a year, they found once again that the ICS-LABA, when required, had a similar effect on exacerbations. So a really good body of evidence. But actually in this more pragmatic study, they actually found for those more severe exacerbations, so those requiring oral steroids, ICS-LABA combinations appeared to be best. They also found that both ICS-LABA when required and the fixed dose reduced the time to first exacerbation and appeared to have a similar effect on the inflammation in the airways. Further pragmatic studies have gone on to be done to look at exactly the same thing. So big studies, 890 patients with mild asthma, showing again and again that actually ICS-LABA when required is as good as ICS fixed dose combinations in reducing exacerbations. And both of those treatments are far better than just using short-acting bronchodilators, with again the advantage you can use less inhaled corticosteroid when you use it as and when required. And this led in 2019 to GINA changing its guidelines. GINA now recommends the use of ICS-LABA combination inhalers when required throughout the treatment pathway. We haven't quite caught up in the UK yet with the British Thoracic Society guidelines, and those are currently going through a further review. But certainly locally in our regional guidelines, we've built this into our guidance now, advising the use, and we're anticipating a license in the UK for inhaled corticosteroid LABA combinations at step 1, so the first level of treatment, later this year. And that's going to be a real game changer for us in terms of treating patients, because we're going to be able to give patients a treatment they can escalate as they go through the algorithm, but a treatment they take at the time they need it. So what's the problem with inhaled steroids? Well, we are seeing an increasing concern about, are high doses of inhaled corticosteroids safe? We're seeing increasing, we know the literature shows that there are, increasing problems of adrenal insufficiency and systemic adverse effects from using these high doses of inhaled corticosteroids. We have seen this replicated, and these are some of the evidence that was presented at the recent BTS meeting around the fact that we do see adrenal suppression. And there are concerns about the impact this might have on the lung microbiome, but also the fact that there is a potential that if you suppress T2 inflammation, you might polarize patients to this different Th17 type of inflammatory cascade, which is much more neutrophilic. And there is this increasing concern, are we driving people to a neutrophilic phenotype with our inhaled steroid use? So we do have to be careful. But as I've said, with the ICS LABA at step 1, you can use lower doses. And we also have a huge focus in the UK at the moment about MART therapies. So MART therapies, this is using the same drug as a maintenance and a reliever therapy. And this is possible because we know that formoterol works as quickly and as effectively as salbutamol. And so therefore you can use drugs that contain formoterol as a reliever medication. We also know that there is an opportunity in asthma where there's an exacerbation to act early. So this was the study by Tattersfield, that was published in the Blue Journal some time ago, but it looked at asthma exacerbations in over 400 patients. And what you can see here is there is a window of opportunity where symptoms increase, short-acting bronchodilator medications increase before an exacerbation occurs. So what does that mean in terms of how we might treat patients? Well, we know with asthma that symptoms vary from time to time, over time, sorry. So day to day, there's a fluctuation in symptoms. That's the hallmark of asthma. And what we do for our patients at the moment is we generally give them a steroid inhaler periodically. So they may take 1 puff in the morning, 1 puff in the evening, for example. And that's the orange inhalers on this graphic. But then we ask them to use their blue inhaler or their short-acting bronchodilator when their symptoms get worse. So if we think about what happens during the exacerbation, symptoms get worse. That's the hallmark really of an asthma exacerbation. And the reason for that is that lung function gets worse. So as their symptoms are increasing because their lung function is worsening because they have bronchospasm. And so what we do is we continue their inhaled corticosteroid and we try and give short-acting bronchodilator medications to treat that bronchospasm. The problem is what you're doing there is you're ignoring the main problem, which is the reason for that bronchospasm is inflammation. And so what we do is give lots and lots of short-acting bronchodilator medication, which might improve their symptoms, but it doesn't treat the main problem. And once their inflammation reaches a peak, we give oral corticosteroids because there's no other way of treating this. So what about a different way of treating this? Because actually we're treating the consequence, not the cause. And so what we're turning to now, and this is an example for Symbicort as a turbohaler, giving the same treatment and using that as their reliever medication. This means that patients will take more as their inflammation worsens because they get more symptoms. And as their lung function worsens, they're taking more bronchodilator, but they're also taking more anti-inflammatory therapy. So this means that you can treat the inflammation and reduce the inflammation. You can improve the lung function, and you can actually avoid the need for oral corticosteroids, and the patient's symptoms will improve. So a different way of managing things that allows us to really avoid the need for oral corticosteroids, but perhaps also really importantly, reduces the need for short-acting bronchodilators. I'm going to come on to talk a little bit more about this, but short-acting bronchodilators account for about 80% of the carbon footprint of inhaled treatments. And therefore, we do need to think about ways that we can reduce the use of short-acting bronchodilator inhalers. So in this context, you're treating the cause and the consequence. So perhaps seems very straightforward, but really we do need to educate our patients about this so they know exactly what to do. Patients need self-management plans so they understand how to manage their asthma. So a slightly different tangent now, thinking about phenotype targeted therapies. So many of you be familiar with severe asthma. So this is the other end of the spectrum. These are patients who we're confident they have asthma. We've treated their comorbidities optimally. We know they're taking their treatment and we know their inhaler technique is effective, but despite high doses of treatment, they still are not managing and their asthma is still poorly controlled. So these patients are a real problem for us, and it reflects about 5% of the asthma population. And these patients suffer by far the greatest burden of asthma morbidity and mortality. They suffer very significant symptoms which persist. They suffer more frequent and severe exacerbations. They suffer a very significantly increased decline in their lung function. And as I've already highlighted, they have the greatest mortality. But also we see these patients suffer a huge impact on their quality of life. They can't work. They have a huge burden of anxiety. They often become incredibly isolated. They suffer a huge financial difficulty and a loss of independence. They often need somebody around them all the time in case their asthma symptoms worsen. And in the UK, what we see is they're an incredibly expensive population to manage. So of that £1 billion I was talking about, it's thought that about 40% of the overall direct cost of managing asthma is for this group. So 5%, but 40% of the overall costs. And it's really important when we think about this group, why do we struggle? It's because of the heterogeneity of asthma. We consider asthma to be one condition, but it's not. It's an umbrella term for quite a broad group of conditions. These are patients who usually have chronic airway inflammation. They have some symptoms which are suggestive of asthma, so wheezing, breathlessness, coughing, for example. And those symptoms tend to vary over time. But what we now know about asthma is that that is a different range of conditions. And so the concept of phenotyping has evolved over the last 20 years or so. And phenotyping is where we try and subgroup those patients with asthma so we can work out which treatments might work better for those different patients and what the longer term outlooks might be for those patients. And so those are the kind of shapes that I'm showing here. So the different groups of patients that might need different treatment strategies. But over the last 10 years, what we've really seen is actually phenotyping is helpful and it gives us disease subtypes. But if we're really going to make progress towards truly having patients without symptoms cured of their asthma, we need to think of endotypes. Endotypes are the specific pathobiological pathways that underpin the different asthma phenotypes. So what are the processes and pathways in the airway that cause these problems that we can target with very specific treatments to get our patients better? And very importantly, we need to have biomarkers so we can identify those subtypes so we can treat them effectively. And the concept of biomarkers and subtypes in asthma isn't new. I'm sure many of you will be familiar with this landmark study, which actually was published in 2009. And this was Woodruff's work, which looked at the different subtypes of asthma. And they took a whole group of asthmatics and control patients, and they looked in the airway epithelium for an IL-13 signature. And then they took these patients with these signatures and without these signatures, and they categorized them as Th2 high and Th2 low. And when they looked at the Th2 high group, they saw that they had that cytokine expression that we all associate with T2 asthma, so IL-4, IL-5, and IL-13. Being the key cytokines that drive the inflammatory process in that group. And when they looked at those patients, it was Th2, that phenotype, that was associated with having eosinophilic inflammation in the airway. But I think the most important finding of this study was when they took those patients and they gave them inhaled corticosteroids, it was only the patients that had a Th2 signature in their airway that got better with inhaled steroids. There was no difference seen in the Th2 low asthma group. So really important to recognize that we do need to make sure that we understand what we're actually treating. And the concept of phenotypes has evolved a lot over the last sort of 10 to 15 years. And what we now know is there are very discrete subtypes of asthma that need different treatments. And that is incredibly important for our patients with severe asthma, because we need to make sure that we recognize that they have different conditions that we need to treat. And you can split this out in different ways. So this has been split out using the presence or absence of eosinophilic inflammation alongside symptoms. And this is a big cohort from Leicester. And what they found in that was, yes, you've got some patients who've got the early onset atopic asthma. And in that group, these patients do follow the stepwise treatment algorithm that we would give. So the more inflammation they have, the more symptoms they get. But they also found patients who've got huge amounts of inflammation and no symptoms. These patients will develop very significant lung function impairment without any obvious cause, but also patients who've got lots of symptoms, but no eosinophilic inflammation. These patients often end up on huge doses of oral corticosteroids, which they'll get no benefit from, but suffer all the side effects. And that can become a key driver for their condition. So what about identifying different asthma subtypes? Well, I want to show you a little bit of the biology. I don't want to dwell on this, but we are familiar with the fact that there are different pathobiological processes in asthma. So we have the normal airway epithelium, airway smooth muscle. And we know that there are allergic eosinophilic asthma patients. These are patients who are driven by that Th2 response, Th2 activation by allergen exposure, triggering off the IL-4/5/13 cascade, which causes the influx of eosinophils. It causes that transition to an allergic phenotype with IgE produced to specific area allergens, and that priming of the airway. So when they're re-exposed, their eosinophils, mast cells, and basophils will cause that very significant type 2 reaction. We also know about non-allergic eosinophilic inflammation. So these are patients where other things are triggering their airway epithelium to drive a type 2 response. These are driven by ILC2 cells in the airway, but again, eosinophils. And these patients are very type 2 sensitive, and they will have conditions such as nasal polyps and other things associated with them. And we often see this as a sort of later onset asthma phenotype in our patients. Then you've got patients who don't have predominantly type 2 inflammation. These patients often have neutrophilic or mixed granulocytic infiltration, and often they have a Th17 signature, which is thought to drive their underlying airway neutrophilia. And then you've got patients who have no inflammation at all, but they have smooth muscle changes and lots of airway hyperresponsiveness. And we know that there is underlying airway remodeling occurring. So our patients are suffering the consequences of their asthma as their airways remodel, and they often develop lung function impairment. Type 2 asthma is by far the most important in terms of the treatment paradigms we currently have available. And we know that about 50 to 70% of asthma patients appear to have a T2 signature. Type 2 inflammation is really important because we can identify it also using biomarkers. And you'll be familiar potentially with blood, sputum eosinophils, pheno, serum IgE, and periostin levels, all of which have been used to identify these type 2 inflammatory signatures. And type 2 biomarkers in severe asthma have been absolutely pivotal to helping us select which patients we should give biologic therapies to target T2 inflammatory pathways. And we see by far the greatest magnitude of benefit in those patients who've got a clear T2 signal. So for IL-5 therapies, that's predominantly been blood eosinophils. And then for IL-4/13 targeted therapies, that's been a combination of eosinophils and pheno, which is a measure of airway inflammation. So for those not familiar with pheno stands for fractional exhaled nitric oxide levels. And this gives us an insight into the amount of T2 inflammation in the airway. So when the airway epithelium is exposed to irritants, viruses, or allergens, part of the inflammatory cascade triggers the release of IL-13, and IL-13 causes the implantation of iNOS into the airway epithelium, and that causes the epithelium to create nitric oxide, and you can measure that in the exhaled breath. So it gives us a good idea about potentially steroid sensitive or T2 airway inflammation. And we use that in the UK currently to try and guide diagnostics for asthma. And it can also be used in terms of trying to identify those patients who've got ongoing type 2 inflammation who might be suitable for biologic therapies. But it really is important to highlight, and I won't dwell on this in the interest of time, but actually what we see in severe asthma is we see a huge burden of disease irrespective of that T2 signature, but we do see very profound lung function impairment in those patients with a T2 signal, and we do see the greatest rate of exacerbations in that group as well. We know that combining T2 biomarkers can be really important for us as well to identify that group who are going to be responsive potentially to the treatments we have available. So what are these treatments? Well, these are biologic therapies. So these are really now the mainstay of advanced asthma treatments that we've been using over the last 5 years. For managing asthma. These are also known as MABs or monoclonal antibodies, targeted treatments that target very specific components of the immune cascade to try and reduce the amount of inflammation in the airway. And the idea of these biologic therapies is to improve the things that patients suffer from in terms of symptoms, trying to improve lung function and improve what our patients can do in terms of their quality of life and functional status. But also very importantly for our healthcare economy, reducing exacerbations, reducing unscheduled healthcare use, hospitalizations, and ultimately mortality as well for our patients. We've got lots of different biologics available, and there are more biologics currently in the research arena that we're trialing. But at the moment, the main biologics we have target IgE, and that's Xolair or omalizumab. We've had that for quite some time now, and that's been a very effective treatment over the last 15 years. We also have anti-Isl5 treatment. So these target interleukin-5. IL-5 is responsible really for eosinophil recruitment into the airway, but also eosinophil maturation in the bone marrow, and also the priming and activation of eosinophils. So it really is an anti-eosinophilic therapy. We also now have dupilumab license, which is an anti-IL-4/13 treatment, because it works on the 4 receptor alpha and also IL-13. And that's been incredibly beneficial in the research studies. And actually the evidence emerging is that's got really good real world data as well. And one of the therapies we're waiting that will hopefully be licensed fairly soon is the anti-TSLP. So this is really an epithelial activation cytokine, so much further upstream. So what have we seen with these biologic therapies for severe T2 asthma? Well, we've really seen that with the IL-5 drugs, they have a very good effect at reducing exacerbations and the need for oral corticosteroids. Mepolizumab is given subcutaneously every 4 weeks and was the first of the IL-5s licensed. And really we need to, in the UK, we use blood eosinophils as a biomarker to tell us about the effectiveness of that treatment. Benralizumab has more recently been licensed. That's given every 8 weeks as a subcutaneous injection. Benralizumab works slightly differently, and as well as reducing IL-5, it also acts directly to cause eosinophil apoptosis. So it reduces very significantly and very rapidly the eosinophil numbers. And that's why there has been a suggestion that it may well have a useful role in the treatment of asthma exacerbations as well. And that's a very rapidly evolving sphere in the research world at the moment. Dupilumab is slightly different, and that's given every 2 weeks as a subcutaneous injection. And that's shown really good evidence in terms of reducing exacerbations, but also perhaps more evidence around symptoms and improving lung function and reducing the need for oral corticosteroids again. And that is really the evidence for that around biomarkers very much uses a combination of blood eosinophils showing a systemic eosinophilia, but also FeNO, as I've said, which is a marker more of airway type 2 inflammation. And as you can imagine, given that this drug works on IL-4 and IL-13, the IL-13 pathway for FeNO explains why that's been so useful. The interesting thing about tezepelumab as it comes along is we don't know which biomarkers will be most useful, because in the studies, this appeared to work across all the different groups. In the UK, we have the NICE eligibility criteria for biologic therapies, but these are still very expensive. And so the use is very much restricted to the severe asthma population at the moment, where the cost effectiveness benefit is because of the exacerbation reduction. I just want to show you this slide because I think it's really interesting. We talk a lot about biologics and how effective they are. This is a study from Lewisham, which is a hospital in the UK in London. And this was a study that was done between March and June 2020. And if I were to show you this, say, look at this exacerbation reduction, I think everyone would think it was absolutely phenomenal and one of the best biologics going. But actually what this is showing is what happens when patients wear masks and they isolate as a consequence of the COVID pandemic. And what we saw there in the asthma population was a 70% reduction in exacerbations and an 86% reduction in hospital admissions. So what this is telling us is when patients take their treatment and we take really good measures to avoid viral infections, actually we can see a really big improvement for our asthma patients. Oral corticosteroids remain a huge problem in the UK. And one of the problems we faced is the significant lag in terms of seeing that reduction in terms of oral corticosteroid use. In the interest of time, I'll just move on to the real world data we've seen with some of the biologics. So do they actually help us to reduce our reliance upon oral corticosteroids? And the answer in the real world data is yes. We're seeing equivalent data to that seen in the randomized studies, 70% reduction in exacerbations, 77% reduction in hospital admissions, and big reductions in the proportion of patients who are on maintenance oral corticosteroid in a very real world population. So that's really encouraging for us. But we do face ongoing issues, and this is just around our local provision of services. And I imagine this is very similar. And I know biologics are very expensive, which has hugely limited their use thus far. And we are awaiting the use of biosimilars in the future, which may bring down the cost of these treatments. But one of the big problems for us is that we know that we're still not getting the right treatment to the right patients. And we're seeing spiraling uptake in that use, but we're really still struggling with the uptake to make sure we're reaching the right patients. So we're seeing in the UK now, we're seeing that these are so effective that we're seeing huge numbers of patients that would be eligible and would benefit. And that's having a real impact on our services. I'm just going to move on from these slides in the interest of time, because I want to touch briefly on azithromycin as well, which some of you will be familiar with. So this is the use of a macrolide antibiotic therapy. So this was the AMAZES study. So this was another big study, 420 patients, where they used azithromycin 500 milligrams 3 times weekly in patients who were requiring inhaled corticosteroid LABA combination therapies. And I just emphasize this because, you know, we talk a lot of biologics, but again, we're seeing other treatments that can have a real benefit across the different asthma phenotypes. And in this study, what we saw with azithromycin prophylaxis was a very significant reduction in exacerbation frequency as well. So this is for your more severe patients where we're comfortable that they don't have non-tuberculous mycobacteria or other infections. We would use this prophylaxis, and we have seen very significant benefit from this treatment, but it can be limited by side effects. So diarrhea is quite common in this group due to the use of a long-term macrolide. We also think a lot about severe asthma and fungal exposure and sensitization. We know this is a real problem for our severe asthma population, particularly around thermotolerant fungi. So these are fungi that can live in the lung, and the main one we see in the UK is Aspergillus. And we know that patients who've got fungal colonization of the airway, particularly in the context of severe asthma, do have significantly worse outcomes. And this can drive the lung function decline in these patients and the exacerbation frequency. And I just want to highlight this study because I think it's really important. We talk a lot about the use of very high doses of oral corticosteroids for the treatment of ABPA, but actually there is really good evidence from the MIPA study, which I think is overlooked, about the benefit of itraconazole in these patients as well. But it is important to recognize the toxicity and the potential risks of resistance with itraconazole use. But in this study, they randomized patients with ABPA. So these were patients with the classic phenotype. So they had asthma along with evidence of ABPA based on immunological testing. So an IgE above 1,000, these patients had evidence of a specific IgE being raised to Aspergillus with a raised Aspergillus precipitans, and evidence radiologically of either central bronchiectasis or other features consistent with ABPA. And they saw in this group, when they looked at composite response, it was slightly better in those patients who were given prednisolone, but they were given huge doses of prednisolone. And I think we do have to think about the cost. Whereas actually the patients who were given itraconazole also saw a very significant benefit. So I know we wanted to touch a little bit on the carbon footprint as well. So I just wanted to talk about that because that's really topical for us at the moment. And the NHS in the UK is responsible for about 4% of the total emissions for our country. And so it is really important we think about this. And inhalers account for about 3.5% of the total emissions for the NHS, which is really quite staggering. And we know the majority of that in the UK comes from MDIs, and the majority of MDIs that are prescribed are short-acting bronchodilators. And if you think about the use of these inhalers and you contextualize it, it is extraordinary. So forgive me, because this is an analogy which is probably more relevant to those in the UK, but nevertheless, this is a significant flight between London and Germany that would equate to the use of somebody using one of these inhalers just for 6 months. We know that PMDIs are responsible for the majority, and that's because of the propellant that's in these drugs. And we know that the range of carbon footprint between these inhalers is also quite variable, but it is really important as a mainstay to think about using dry powder inhalers as the first line because they don't have propellant. But that does have to be balanced against the fact they do have more plastic. So nevertheless, there is a cost, and the industry need to start providing us with these costs. with the carbon footprint, but it needs to be in a way that we can understand. So cradle to grave carbon footprint, so we can drive down our use. But when we looked at this in our own hospital, we found that we are doing badly. We are prescribing far more PMDIs than DPIs. So we've had a major change on our prescribing practice, because when we equated this, actually, we worked out that we were using purely in our PMDI costs, we were essentially using the same carbon footprint as driving around the world 4 times in an average car, and that can't be acceptable. So we have lots of initiatives going on at the moment, and one of these, this is our local guideline to share with you again, is that we've now included carbon footprint data into our prescribing guidelines to try and encourage people to use low carbon inhalers wherever possible. So thank you for listening, and please do ask any questions if I can answer any questions.
Yeah, there are a few questions. The first one is that in patients who have moderate symptoms, which level do they start, and the GINA guideline, they start the asthma treatment on? So I think you went through that.
Yes, it's an interesting question, because people often think the more symptoms start at a higher level in the algorithm. There's very little evidence for that. In fact, I would not use that as a guide. In the vast majority of patients, we would start the treatment at the low dose ICS and build up from there. Perhaps the one exception to that is the patient who's been to ITU. When they're discharged from ITU, then I think it would be very reasonable to consider whether you might want to consider additional treatment at that stage if you're very concerned about it.
Yes. And just to add to that, we've seen a lot of patients in Sri Lanka who are on oral bronchodilators. At times they are on Theophylline, started in the clinic, and then it just keeps continuing for months and even years. Do you see any benefit of that?
No, we rarely use oral theophylline now, and there are oral salbutamol tablets and Bambuterol, which is a long-acting beta agonist. We rarely use those. Inhaled therapies are more effective and they have less systemic side effects, so they are safer for patients. The challenge with theophylline is that they have quite a weak bronchodilating effect. They do work in some patients and they do have a role, but they are nowhere near as effective as the other treatments which are available. They're also hugely impacted by smoking, so the levels can change quite dramatically in patients who smoke and then stop smoking, for example. And in smokers, you'll struggle to get therapeutic levels that are effective, actually.
Yes. And the next question is, why does the type 2 inflammatory phenotype poorly respond to steroids?
So it's an interesting question. It's to do with the pathobiology. So usually the Th2 response, so the allergy-driven response, does respond well. And that's because Th2 cells are steroid, we think are more steroid sensitive. How steroids work is interesting because it's still very poorly understood. But it does seem to be more effective in that phenotype. However, ILC2 cells, which are thought to be one of the major sources of the inflammatory cytokines in those patients with type 2 or eosinophilic asthma, particularly those later onset with nasal polyps, that kind of phenotype, those are very refractory to steroids. And in fact, you see a very little effect or benefit from steroids in some of those patients, or you often need to use very high doses of oral corticosteroids. And the other is that you do see these mixed phenotypes where you have neutrophilic and eosinophilic inflammation. And in those patients, you often see very little impact. Steroids will have very little impact on the neutrophilic component of that inflammatory cascade. So it does appear to be, there are different types of type 2 inflammation. So we group it conveniently as being one type, but it really isn't. There are very different subtypes within the T2 population.
Yes, thank you. And yeah, just before we started the session, we were talking about Bronchothermoplasty. So the next question is by another consultant who wants to know the indications for Bronchothermoplasty in severe asthma group.
Yes, so we've seen a huge benefit from biologics. So we have moved much more to biologics at the moment in UK practice. We do still use thermoplasty. I think thermoplasty has a real role in those patients who have a lot of bronchial hyperresponsiveness. and they seem to have very little by way of airway inflammation, but a lot of airway hyperresponsiveness due to presumably smooth muscle changes, but often as well due to perhaps some of the changes in terms of the airway nerve burden. So they may have an increase in the number of airway nerves they have, and that causes these patients to be quite bronchospastic, and that might be a subgroup that do benefit. We've really struggled, despite several studies, to identify the population that benefit the most from bronchial thermoplasty. And just speaking of local experience, the patients that we have treated, actually we have seen some very significant benefits, but sadly that hasn't been long-lived. In those patients, it tends to have lasted for a couple of years, and then they have relapsed with their asthma symptoms. And in the majority of cases, the biologic has been the more effective therapy. The other thing to say is that as we've seen benefits in terms of lung function with some of the newer biologics, then again, that has led more to a drive towards those treatments. And of course, in terms of a cost delivery, the biologics can be delivered often via home care. It's an injection the patient can do subcutaneously versus the cost of bringing people in. And for those who do thermoplasty, the catheters for thermoplasty alongside the requirement for the equipment setup can be quite costly. Now, clearly, if that was a one-off treatment and it was then curative or led to a very significant and sustained improvement, that would be brilliant. But there are patients, and I have met patients who have had thermoplasty who have had very long and lasting benefit from it. So it's definitely a treatment we need to revisit, but understanding the phenotype is really difficult. I certainly wouldn't do it for those patients who've got very significant lung function impairment. So do think about the FEV1 in those patients, because all of the patients we've treated have suffered quite significant exacerbations, usually after the treatment. And so therefore you do want to make sure those patients are safe.
Yes. The next two questions are both, again, I think we just covered about the oral medication. Again, on the use of theophylline in asthma management and the leukotriene inhibitors, montelukast. Do you think they're used long-term? I mean,
montelukast seems to have a dramatic benefit in some patients, but again, it's hard to pick the phenotype because we don't necessarily understand the pathway that generates, that group of patients. We used to think it would be the aspirin sensitized patients because that seems to be a drive to go down that pathway, but we haven't really seen that. We try it because it's a relatively inexpensive and relatively few side effects in terms of that treatment. It remains very popular in pediatric practice where they have a lot of atopic asthmatic children, and it can be very effective in that group. So yes, absolutely. After trying, so in terms of the network meta-analysis, which is the general way of looking at which treatments to add in at which stage, our practice is usually to give an inhaled corticosteroid and then to give an inhaled corticosteroid LABA, and then to give an inhaled corticosteroid LABA with a montelukast trial. Zafilukast is no longer available to us, so montelukast is now the only leukotriene receptor antagonist we have available for treatment. But yes, it can be extremely helpful and extremely useful. But again, if it doesn't work, don't continue it. So it's not having some subtle subliminal benefit that you're missing. If the patient feels they've gained significant benefit from it, then continue it. Usually it's patients who are allergic. Usually it's patients who've got that combination of allergic rhinitis and asthma who will be the most likely to benefit, but try it and see.
Yes. And that the next question is, at what stage would you consider Llama therapy?
So in our current practice, what we're saying to everybody is don't add a long-acting antimuscarinic therapy until you've phenotyped your patient, by which we mean see whether you think they have got type 2 inflammation, which is persisting, or whether they've got predominantly airflow obstruction. And this is a group of patients who are usually on a moderate dose of an inhaled corticosteroid and a long-acting bronchodilator, plus or which is a beta agonist in that context, plus or minus montelukast, depending upon whether it's been effective. So in that group, we will think about adding in either a long-acting antimuscarinic or going up to high-dose inhaled corticosteroid LABA combination. Now, the only way to make that decision is to have phenotyping available to you, because what you want to know is, do you have ongoing airway inflammation? And if you do, I want to give you more steroid. If you don't, I want to give you a bronchodilator. Now, if you don't have access to pheno, other measures would be a blood eosinophil count. So we recommend to our primary care teams to use blood eosinophil counts above 0.3 as a marker of potential type 2 phenotype. Patients who have early onset asthma, that can be associated often. So that might be a good signal to think about type 2 asthma. The other is if a patient's got nasal polyps or other conditions that might be associated with T2 phenotypes, or if they have an atopic allergic phenotype. So those can be things that might steer you in that direction. But the truth is, at that stage of your treatment algorithm, you really want to be trying to work out what is the problem for this patient, rather than if I take a whole load of patients, which is the more likely to be beneficial. By the time you reach that stage, it should be trying to achieve a more personalized therapy.
Yes, and the next question is quite a common question. They would like to know what is the best in efficacy wise for patients, an MDI or DPI inhaler?
Yeah, there is absolutely no evidence that one is better than the other. But we see the vast majority of patients with asthma can use a dry powder inhaler very effectively. And actually, when you think about it, with a dry powder inhaler, the patient is driving the inspiratory force. So the patient is in control of that. With a PMDI, actually, what you're doing is you're firing the medication out of that device, and you're firing it out fast. And the patient then has to coordinate getting that into some form of laminar airflow past all the upper airway down into their lungs. So nobody should be using a PMDI without a spacer. So essentially, if they're going to use that, it can be really difficult for them to coordinate that without using a spacer. And when you look at all the studies, look at the radiolabeling, you get very small amounts of the PMDI down into the lungs. But ultimately, there will be a small proportion of patients that can't use a dry powder inhaler, but the vast, vast majority can. But there is no evidence to suggest that giving the same drugs via either device is superior. But probably there is a very significant, well, there's definitely a very significant environmental benefit. And definitely when we watch patients using their inhalers at the time of an exacerbation or a worsening of their symptoms, the majority fare better with a dry powder inhaler because they are controlling the inspiratory flow. So the coordination and the timing is a lot easier for them.
Yes, thank you. And the next one is about emergency management. What is the place of repeated doses of magnesium sulfate in acute severe asthma management?
Again, the jury's out, isn't it? But I think when your back's against the wall, using more than one dose is something that we all do because it does have some bronchodilator effect, but there is no evidence. I think you have to be very careful of the arrhythmogenic effect of giving multiple doses of magnesium if you're then planning on giving, for example, IV aminophylline or IV salbutamol to that patient, because you do need those patients to be on a cardiac monitor. There is really no evidence that giving a second dose has an additional bronchodilator effect that I'm aware of. And I think, but, you know, in these patients where you're trying to avert the risks of an intubation, which is a very, challenging intubation in an acute severe asthma patient, then it can be, can be tried. We do sometimes give it the second day where those patients will relapse. So there's nothing wrong with, I think, giving it if there's been a gap between those two dosings. The other thing is there's no evidence for giving a slow infusion afterwards. So we have seen some practice whereby we give, because obviously you give this as a more rapid infusion than you would if you were simply trying to replace magnesium, because you're trying to get a bronchodilator effect from it. There is no evidence for following that up with a longer magnesium infusion afterwards at all, and I wouldn't encourage that practice.
Okay. And the next one is part of COVID as well. Since COVID has come in, we have seen a lot of patients with bronchial hyperresponsiveness, especially in the elderly. Do you continue inhalers long term for them, or?
So the patients that we've seen, no, unless they've got so it's a post-infective bronchial hyperresponsiveness pattern rather than being a new onset of airway inflammatory change, as far as the majority of those cases go. So we would normally treat them for a period of time and then if they're symptomatic and it's causing, you know, a significant impact on their quality of life. The difficulty with the COVID patients we've seen is a lot of them suffer with fatigue and breathlessness as a consequence of breathing pattern disorders afterwards. And so, you know, trying to unpick that, because otherwise, before you know it, you'll have a patient who's very reliant on their short-acting bronchodilator, physically very deconditioned because they're not doing anything, telling you they've got severe asthma because they're not managing, and actually what they have is the consequences of their COVID. So very important that these patients are encouraged to get back to regular physical activity. So I do think in that context, it's good to give them, you know, treatment if that's helping them to actually you know, restart exercising some level of physical activity. I think otherwise we would base that treatment based on whether they have evidence of airway inflammation afterwards. I certainly wouldn't encourage long-term treatment on that basis, because the majority of these patients do seem to settle. And actually, when we've looked quite hard at some of these patients with a post-COVID breathlessness, we found relatively little evidence of asthma and a lot of evidence of breathing pattern troubles, which respiratory physiotherapy is good for. And there's a website, Physio for BPD, which can be extremely helpful as well. And it gives all of the exercises. And there is a section on trying to manage that post-infection syndrome. And I would encourage you to steer patients to that or other resources for them to try.
Thank you. And is there an advantage of giving vitamin D in asthma?
Yes, this has been, we do replace vitamin D for our severe asthma patients. There's lots of theories as to why that might be beneficial. One was was thought to improve IL-10 function, so that sort of anti-inflammatory immune function. The other question was whether it would be beneficial in terms of efficacy of inhaled steroid treatment, or steroid treatment improve the efficacy of that. We do find that patients do benefit from having their vitamin D levels supplemented, particularly when it's low. I think the jury's out on those patients in the middle ground, but I have to say, for us, a lot of patients who are on high doses of inhaled corticosteroid or on maintenance oral corticosteroid, we would be looking to give them a vitamin D supplement as a matter of routine. For those other patients, we do replace it, and patients tell us they feel better. There isn't a good body of evidence to tell us whether that is a immunopathological benefit or whether that is more of a placebo benefit that we're seeing. And the placebo effect in asthma trials is always very high, so you do have to be quite careful with it.
Yes, thank you, Dr. Brown. And there was one more about, should we prescribe ICS/LABA only as an SOS basis or on a daily basis?
So I think at the moment, if you have a patient, and you must make sure you don't fall foul of licensing criteria. I think the license for an ICS/LABA, I share that as relatively new information, and that is now licensed practice in Europe. We are waiting for a license in the UK, and I don't know whether there is a license for that treatment as yet in Sri Lanka. So obviously it's important to make sure that you take that into consideration in terms of your prescribing. But I would be using ICS/LABA treatment when required for the first line treatment. So when you start a patient on treatment, that would be the first line. When a patient isn't managing with that, then you do need to think about stepping up and instituting some maintenance treatment. But one of the main drivers behind that is because we know when we prescribe regular treatment, patients don't use it. So trying to keep that as minimal as possible can be helpful. Trying to keep things as simple as possible, which is why I talk about maintenance and reliever therapies as well, is really helpful for our patients. So if you can give them the same treatment that they take regularly, but they're also using for their reliever medication, that's really important. But just to emphasize, you can only do that with formoterol containing drugs. You can't use that for any other drugs. And the reason is formoterol works as quickly as salbutamol. Drugs like salmeterol do not. So therefore, you can't use that as a quick reliever medication. So you cannot use drugs like Seretide or drugs that contain, so Relvar, which contains vilanterol or olodaterol. These drugs you can't use as a maintenance and reliever therapy, and you can't use it as ICS/LABA as and when required, because they won't work quickly enough to have that reliever benefit.
Okay, yes, thank you. And the last question is, how do we manage asthma with CO2 retention? Is there a place for NIV at this point?
So in the acute setting, no, not unless they're in an intensive care. If a patient has CO2 retention in the context of an acute asthma exacerbation, then you may wish to try treatments with positive pressure in that setting where you can rapidly intubate the patient, but never in any other setting. And I wouldn't recommend that other than under the supervision of an intensivist. In the more chronic setting, it's very similar in many ways to the COPD population. They develop CO2 retention. And actually for those patients who've got a chronically elevated bicarb, we know from the hot HMV studies and other studies that in COPD that can be beneficial. And I think in that context, the severe asthma, chronic asthma patients are really in a very similar situation with chronic airflow limitation, which is the cause of those symptoms. And so therefore, I don't think it's unreasonable to consider it in that population with chronic long-term CO2 retention as a consequence of end-stage lung disease, but never in the acute setting unless you're in an intensive care and you have that ability to intubate that patient.
Okay, Dr. Brown, thank you very much for answering those questions. And I'll hand it back to Dr. Niroshan.
I'd like to thank Dr. Thomas Brown for a very enlightening lecture on this very important topic. It was really huge as well. Thank you. So additionally, I'm grateful to Dr. Riaz Mawjood and Dr. Chandiman Indugodage, consultant chest physicians, for organizing this session. And I should also mention Mr. Nalina and team for technical support. Finally, I thank all of our online participants for your active participation despite your busy schedule. Good night.